sudden onset of development of oliguria and hematuria, and then develops swelling. Hematuria and maybe not gross hematuria, but hematuria, oliguria and even swelling is a feature of nephrotic syndrome. How is it different? Which patient will be nephrotic syndrome? So, it is very important first to characterize your patients into syndromic diagnosis. So, let us see if you can identify people with syndromic diagnosis. So, how nephrotic syndrome also has oliguria, has some proteinuria and swelling in the urine. So, there are many components of these symptoms which will be prevalent in many of these syndromes. The challenge and the understanding that you need to have is how would you distinguish these symptoms to characterize them into a different syndromic diagnosis. So, when you present your patients, you say this is nephrotic syndrome, this is rapidly progressive renal failure, this is an acute nephritic syndrome. So, what would be nephrotic syndrome?
So, they would have proteinuria first and oliguria would develop later.
And in acute nephritic syndrome, the oliguria is because of what? In nephritic syndrome. In nephritic syndrome, oliguria is because of?
The tubules getting blocked because of the casts and
Is that the reason? Is that the reason? Why do they get oliguria? Acute nephritic syndrome.
decreased filtration is
Yeah, decreased filtration. Yeah. There is swelling in the glomerulus and there is decreased filtration. So, there is decreased filtration. Tubules in fact absorb all that goes out. And whenever there is decreased filtration, kidney gets a feeling as if there is less volume in the body because the GFR is gone down. So, it absorbs. Tubular absorption, if it is 60 to 70%, it becomes 90%, more than 90%. So, it will absorb all the salt and water that goes. So, very little goes to the distal tubule, and that is the reason for swelling and oliguria in these patients, and the swelling which occurs is because of salt and water retention, and they develop hypertension. So, hypertension is a usual feature, and many of these patients may present with left ventricular failure or heart failure also because of hypertension. Hypertension can be severe because this is something which happens very acutely, and this acute hypertension can sometimes be severe and they can cause breathlessness, and many patients may have heart failure kind of symptoms. They will present with that because this is a acute syndrome. This is not there is no disease, underlying disease immediately. It has happened all of a sudden, and then that is what. Nephrotic syndrome gets edema when? And it is because of what? Hypoalbuminemia. Are you sure that it is because of hypoalbuminemia? Overfill and underfill theory. So, both are possible because there are a lot of conditions where albumin could be very low or absent. In analbumic people, in fact, do not have edema at all. There is zero albumin, no albumin, but they do not have any edema at all. So, it is because of again salt and water retention, but mostly related to either a primary salt, which may be related to some of the changes, hemodynamic changes which occurs, and then specific proteins being liberated, and then obviously reabsorption of sodium occurring at the ENaC channels and all that. So, those would be the kind of things which may, or it may be because of an overfill kind of. Okay. So, that is when edema occurs. So, edema is not necessarily a presenting feature of. So, proteinuria occurs over a period of time. It may be asymptomatic, patients may never know it. They may get to know about it only when edema occurs, because they may not necessarily look at the urine froth and others, and all may not have western toilets. So, they may never be getting to know whether they have froth in the urine or not. So, they may not, unless they get edema, that time they do not know. So, therefore, many times your patients you are not sure they get edema. Now, is it acute nephritic syndrome? Is not. So, it is important to delve into history to see as to whether your patient fits into an acute nephritic syndrome, a rapidly progressive renal failure syndrome, which is again another syndrome, or is it a chronic kidney disease, which is the common garden variety of patients that you will see in the clinics every day. Is it a chronic kidney disease? So, you need to initially in your thought process, whenever you are listening to the history, that where does it fit into? So, it looks like this patient, at least till this period of time, looks to be an acute nephritic syndrome. It is possible that later on, when you start analyzing physical examination, and there may be a blur between these syndromes, and you might put your patient somewhere which you thought initially was acute, could be a rapidly progressive, because the history now evolves into months, and then it might become a rapidly progressive renal failure. So, by the end of the story, you might be able to change them, but thought processes must start working the moment you start listening to you. And then your next questions and specific questions that you would want to answer, to get answers to, would be also very, very important. Yes. So, what happened later on?
She was evaluated for the arthritis which was there in the year 2009, which involved mostly the small joints of the hands, which were more than 30 minutes, and maximum the stiffness which lasted for more than 30 minutes, and maximum in the morning. And for it, she was given with small doses of steroid, as she remembers, over the next 6 to 7 months, and there was no history suggestive of any steroid related toxicity. For the above complaints of this red color urine and decreased urine output, she was taken to a nearby hospital and evaluated for in detail, and she was told that she had a disease with a test called ANCA positivity, and rest of the tests were found to be negative at that time. And the kidney biopsy was done, which was with no complication, and they couldn't recollect the report findings. She was treated there with steroid doses for 3.
This was at the local place where she lives?
Yes, sir.
Okay. Where does she live?
Sir, Aligarh, UP.
What?
Aligarh, UP.
Aligarh. Okay.
So, she was given with high doses of steroid for the 3 days consecutively, followed by oral steroids. Due to the non-responsive to the steroid bolus doses, a special injection which he recollects the name as cyclophosphamide was also given, but still the symptoms didn't improve, and she remained anuric. At this point of time, she was planned for a special dialysis with plasma products, and she remembers there was a total of 5 sessions of this dialysis was done, and her renal function improved after the 3rd session of the this dialysis modality, and urine output improved up to 1 to 1.5 liter. Gradually she recovered to be discharged after 1 month of hospital stay, and she had creatinine of 2 mg per deciliter at the time of discharge. This injection cyclophosphamide was continued post discharge, and total 5 doses were given over the period of next 5 to 6 months, including the hospital dose. Later this injection cyclophosphamide was stopped, and she was started with a tablet called Azoran, which was initially started at a dose of 50 mg twice daily for around 4 years, and decreased up to 25 mg twice daily after 4 years. She doesn't remember any drug which was prescribed to prevent any infection any time of during this treatment, and there was no history suggestive of any complication related to this immunosuppressant therapy. She was treated on OPD basis from a nephrologist for this for her chronic kidney disease with oral iron, calcium, vitamin D, injection erythropoietin during the initial period of the disease, and she had a baseline creatinine of 2.5 mg per deciliter, and she was vaccinated for hepatitis B, influenza, and pneumococcal vaccine. She was doing apparently fine when during her routine evaluation in November 2024, it was found out that...
So, 2024,
yes,
till that period of time, she was continued on some of these drugs.
Yes, sir.
And she was treated like what was considered to be an ANCA positive disease. She
yes,
at least told
yes,
that this was an ANCA positive disease. So, now you see 2012, she was treated with high dose of steroids that was given. So, she probably received methylprednisolone and then oral prednisolone and then also received cyclophosphamide and then was also given plasma exchange. So, what kind of biopsy would you? Now, if you were to look at what kind of biopsy would be, what kind of biopsy do you think? What is it that you will feel that the biopsy would be like? See, in this patient, if you were to predict the biopsy, what would you be like? What would be the
would be Crescentic, with Crescent, sir.
with Crescent? So, what kind? She was anuric for fairly good
Yes.
number of days or maybe a month or so, isn't it?
Yes.
So, she was anuric. So, what would be? Would you be more specific about the kind of crescents?
So the crescents
With the-
might be in different age groups, sir, and plus it might be some fibrocellular or fibrous type.
Cellular crescent.
So, this would be what percentage of glomeruli would be?
Around 50%.
So, more than. So, you will feel that this is a diffuse kind of crescentic glomerulonephritis. So, would you feel that the crescents would be fibrous or cellular?
Is the kidney function dissolved on that?
Yeah. So, you would think that these would be cellular crescents. If this was a fibrous, predominantly fibrous crescent, so predominantly you would say there could have been some crescents which may have become. And would you be surprised with that there may be some crescents which may be fibrous? Why would you not be surprised? Suppose I say this is anti-GBM disease.
In anti-GBM, usually have of similar age groups. These cases.
Yeah, so it's a one-hit disease. Vasculitis is a multi-hit disease. It relapses and remits, and each relapse may be very, very different. And the disease onset you don't know, whereas for anti-GBM disease you know the onset. Okay? So, that is the difference between these. So, you might find different levels of crescents in this. So, there could be a fibrous crescent, there could be a fibrocellular crescent, and there could be cellular crescents in them. But by and large, one would think that significant number of glomeruli must be with a cellular crescents because the kidney function improved. Any other difference between say anti-GBM and ANCA crescentic nephritis? So, you have now two diseases which could cause crescentic glomerulonephritis. One you said is that there is different ages of glomerular involvement. There could be a fibrous, totally fibrous, sclerosed glomerulus. There could be also another one which has cellular crescent, and there could be in between fibrocellular crescents, and some areas may be acute tubular atrophy, and there may be other areas which may be perfectly okay as far as tubules are concerned, mild inflammation here and there. So, this is one kind of a scenario. In crescentic with anti-GBM, you will either have cellular crescents or you will have fairly fibrous or fibrosal. So, same age involvement of the nephron. All segments of nephron may be involved to a similar extent, and that is the difference. And therefore, if you have a severe disease, they do not respond to therapies, because with severe disease, dialysis dependent, unlikely to respond to. Whereas, in patients with advanced ANCA positive vasculitis, advanced disease, creatinine 6, 7, in this patient also she was anuric for many days, if not a month. Disease must have been fairly severe with obstructive glomeruli, with almost strangled glomeruli with crescents. But you will continue to give treatment to them. Even with advanced fibrotic, the difference between is that there may be segments of kidneys, because you do biopsy from one segment, it is possible that you may have gone into the worst segment. So, there could be areas in the glomeruli in these where the biopsy might be better. So, in ANCA vasculitis, even though the biopsy looks terrible, the dictum is that you could treat these patients unless there is a significant contraindication to the use of immunosuppressive drugs. Otherwise, you would give them the benefit, and many of these patients will recover their function. They may become dialysis independent, and variable degrees of return of function based on how much is the severity of the disease and the overall kidney involvement. Many of these patients will get surprised. We have had patients who have been anuric and would have recovered their creatinine to 0.8 and 0.9 and remained like that for many years in their life and haven't had a report. So, that is surprise. Severe disease at the time of biopsy, but recovery can be remarkable, which will change your thought process about this disease. So, that is why you need to be aggressive, and the etiology is important. Therefore, finding etiology becomes very important in these cases. So, that's important. So, plasma exchange was the, see, you can see the 2012 understanding of the disease and 2025 understanding of the disease is different. He has raised some of those points. No prophylaxis was given to him for many things that you give prophylaxis today. Whenever you use highly immunosuppressive drugs, you will use prophylaxis for CMV, you could use prophylaxis for pneumocystis carinii, you use antifungal prophylaxis and all. And these were not used in early days of nephrologists, were somehow not very good in using many of these, and these diseases would kill these patients. So, using prophylaxis, as you said that nothing was given to, at least she doesn't know, yes. She may have received, but unusual that in 2012 this was not being the talk of the kind of nephrologist that this would be. The second is the kind of therapy. What would be the kind of therapy if she was? Pardon? Pardon? Yeah, for transplant they were using it, but no, it is not that they were not available, it's only the thought process. No, very little. By and large nephrologists, few nephrologists would use it, but it was not something which was commonly done at that point of time. And the general thought process was that this is a short-term therapy, is not going to be lifelong therapy like for transplants. So, for transplants people were using cotrimoxazole as well as antifungal prophylaxis and all, but for glomerulonephritis treatment, even though the treatments would continue, especially for vasculitis, would continue for 3 or 4 years, lupus would continue also for sometimes even lifelong. Prophylaxis wasn't talked about that commonly in these kind of situations. So, this was neglected area of nephrology at that point of time, and this is a change which is for good. But the kind of therapies. So, what would you, if you had this patient today, so what are the options available for you for this patient? Can anyone talk about options? No, different. See, steroids and cyclophosphamide. Tell me the studies, the trials which came, and then talk about. So tell me the trial. Okay. So what was that trial?
The combination of 2 doses of rituximab plus the 4 doses of cyclophosphamide.
Okay.
Seem to be equal to cyclophosphamide plus prednisolone.
Okay. So you have 2 arms now. You are saying that cyclophosphamide is considered to be a toxic drug. Although in India, since most of us have grown on cyclophosphamide, we've all used cyclophosphamide ever since we were in nephrology and have continued to use it in good stead. So many of us are not as scared of using cyclophosphamide, but world over there are a lot of people who are worried about cyclophosphamide because there are different alternatives available, and therefore, so there has been a tendency to reduce the overall cyclophosphamide exposure in patients with glomerular disease. So the trial, rituximab trial, was to look at combination of rituximab along with, and which was the trial where rituximab was compared to cyclophosphamide? In RAVE trial, yes. So RAVE trial found out what?
So RAVE trial found out that two things actually. So one was that in relapses, in PR3 relapses, this was better, rituximab was better than cyclophosphamide to prevent the relapses. As
far as induction?
Induction, sir, it was similar, but there were more relapses,
yes.
In case of
rituximab. So in the RAVE trial, cyclophosphamide and rituximab are found to be similar as far as the initial response, but the relapses occurred much more frequently
With the cyclophosphamide.
with
Oral
with the
cyclophosphamide.
with not with cyclophosphamide, with rituximab.
Rituximab.
And rituximab was better than cyclophosphamide as far as
Relapse
treatment
is
of
concerned.
relapses was concerned. So, that was predominantly what the message was. So, it turned out that cyclophosphamide is a good drug, there is no doubt about that. And even today, if you have a more severe disease, I would still use cyclophosphamide in my patients in comparison to. But if there are patients who we feel that the patients themselves don't want it, or they are scared about using cyclophosphamide, or there are other people who are physicians who are concerned about cyclophosphamide toxicity in a particular patient, or there are other reasons, then you would maybe use rituximab along with. What is the other change which has occurred?
So the C5 receptor inhibitor.
Pardon?
C5 receptor inhibitor. Avacopan is.
No, that's the other thing. No, I am saying as far as the dosage of steroids.
So low dose steroid.
Yeah, low dose steroid. Which was that?
trials.
Huh?
UVAS trials.
UVAS was
Novas trials. Novas trials.
Lovas.
Yes.
No, Lovas तो नहीं थी.
Pexivas trials.
हाँ जी?
Pexivas trials.
Pexivas trial. Yeah, Lovas नहीं थी. Pexivas. So you.
Novas and Pexivas.
नहीं, Pexivas proved that
Yes.
that was the first trial which showed that low dose steroids is as effective with less side effects, and it is as effective than the standard steroid dosages. So, instead of starting, you could start with 60 milligram, but come quickly down. So, taper your steroids lower down. So, give half a milligram per kilogram body weight and taper them down and maintain them at a smaller dose. So, they are as effective as, so low dose steroids is as effective as the standard dose steroids. So, that's another thing. And then obviously the complement pathway is again opened up, and all those, and those trials are also going to be, and they may become available in the near future and all that. So these are things which are this change of time. From 2012, you can see that more and more trials have come, and you have more evidence to suggest that there can be other drugs which could be effective in patients with ANCA vasculitis in this. So, this is a patient who had ANCA vasculitis, severe form of disease, anuric, and required plasma exchange. What's the status of plasma exchange in patients with ANCA vasculitis? Anyone else? Yes?
So it's done daily for,
But?
daily for 14 days.
No. What was the trial which showed that?
Takes
So, what did the MAPEX trial show? What did MAPEX trial? Have you read MAPEX trial or not yet? You read MAPEX trial? You read it? So, what's the MAPEX trial? You don't remember it? Looks like. No, what was the conclusion of MAPEX trial as far as plasma exchange is concerned? Was it effective or was it not effective?
Sir, it was not effective.
It was not effective.
Yes, negative trial.
So, it was not effective actually. So, in fact, plasma exchange did not. But which were the patients they took?
So they
Creatinine more than 5.7.
Yeah, so inclusion criteria are important. So, they took patients,
More than 5.7 is creatinine.
creatinine,
Plus dialysis dependency.
dialysis dependency, and
Plus hypoxemia.
and
DH was not there, sir.
DH and hypoxemia.
DH was absent in the MAPEX trial.
Yes, these
And present
kind
in
of
the
patients.
Pexivas.
Pardon?
DH was not
DH
taken
was
in
not
the
included.
MAPEX.
Yes.
It was
D-
taken in Pexivas trial.
Yes, they were not included in the MAPEX trial, but they were taken in the Pexivas trial. So, at the moment, clinical evidence would suggest that if your patient is very severely renal failure and has a pulmonary hemorrhage, then in such a patient might benefit with a plasma exchange in these patients. So, 5 to 6 plasma exchanges, she received about 5 plasma exchanges, and that period of time plasma exchange was considered probably to be effective in patients who have pulmonary hemorrhage, and we used to always give plasma exchange to people who had pulmonary hemorrhage or were very severely renal failure. So, severe renal failure and pulmonary hemorrhage would be an indication. Anyway, she recovered significantly and maintained a kidney function of about 2 to 2.5 milligrams over the next 10 years or 12 years.
12 years.
So 24, what happened?
So she was doing apparently fine when during her routine evaluation in November 2024, it was found out that her creatinine was increased up to 3 milligram per deciliter and urine returning showing RBCs without any gross hematuria or any complaints of any other complaints. The creatinine remained at the same level and the urine REM was also of the same in the January 2025 as well, was never evaluated for the same, and the same treatment which was going
There's
on.
one point before I forgot. So now you have this patient and you are the nephrologist, this was your patient and she feels so good about you that she was dialysis dependent and she feels that you did wonderful job that. She doesn't know the severity that the disease would recover on its own, but she will give credit to the nephrologist who got her off dialysis, because generally most people feel कि dialysis के बाद तो कभी बचेगा नहीं बचेगा, और दूसरा, will this patient ever be independent of dialysis? And this lady remains independent of dialysis for 12 years at least. So how will you monitor this patient? What are the things that you will do over every time, maybe 3? You will call her. How frequently would you call her for examination after the recovery? How frequently would you call her for recovery? And what would you do with her?
As such, no guideline is.
One?
As such, no guideline of.
Just don't depend necessarily on guidelines.
So,
use some common sense also.
If there is any disease activity, I will follow for weekly. If the disease activity goes, then once monthly for 3 months. If she remains stable, then 6 monthly. Once.
Yeah, in the initial period after she is just discharged from the hospital, and then she will come for these intravenous injections on him. Either you follow a sort of protocol of giving it every 2 weeks, or you give 500 milligram every 2 weeks, or you give 3 grams, or you give standard dose every month, and maybe give 5 to 6 doses, usually 6 doses. So you will give this and look for whether the patient has gone into a remission and all that. How will you define remission in such patients?
Sir, remission is defined in ANCA-associated vasculitis as per the Birmingham vasculitis score. If it is 0, or if there is a decrease in the ANCA levels or negative ANCA levels from the persistent high ANCA levels, I will call it as remission. Again, the same whenever there
but
is
that's an immunological remission.
Yes.
ANCA coming out, anti-GBM going down, or in membranous nephropathy, anti-PLA2 antibodies becoming negative, would mean an immunological remission has occurred.
For clinical,
but then clinical remission?
I will use the Birmingham vasculitis activity score, BVA score of what has been targeted in the studies is 0 is the target.
Yeah, so would be 0, but clinically nephrologists may not be using many of these scores. See, rheumatologists do it very often, but nephrologists usually don't do these scores as much. But for nephrologists, what is the most important?
Urine routine findings I will check to look for any active sediment.
So one is to look for active sediment. The other?
If there is any increase in her renal worsening of renal function.
No, urine kahan? Urine choda nahi abhi yaar.
Urine routine and microscopy I will do, sir.
Anything else?
And also the protein creatinine.
Yeah, urine protein, that's the most important. What's the predictor of long-term outcome?
Proteinuria.
Yeah, is proteinuria. So if there is a patient who recovers kidney function, creatinine 2.5 by proteinuria 1.5 grams, and another one who has creatinine of 2 and proteinuria of 0.3, so is it different or is same?
It is different.
They are different.
Yes.
They are different. So proteinuria estimation, and unfortunately I must say that nephrologists are poor in measuring estimation of UACR. They don't do it. They look at urine routine examination, and urine routine examination is not a reliable test for estimating proteinuria. And urine routine examination many times is not done very well. Is kept in the lab. I don't know who does it at the middle of night or somewhere, whenever there is, or whether they do it or not, I don't know. So, but we place so much of trust. None of us goes and examines urine yourself. So, you place so much of trust in this urine routine examination, you find no albumin and you don't do urine albumin. So I think it's very important that for CKD, for kidney disease, estimation of proteinuria, and since you can do something about it, therefore it becomes extremely important. It's a target that it should be in your mind. Every time you see a patient, you must know whether your protein is going down, going up, and since you can take care of it. Previously there weren't drugs which we were there that you could do anything about proteinuria that much. But now you can give drugs which may not necessarily be specific for a particular disease, but overall they might reduce other reasons. And proteinuria is an important prognostic marker. In addition to being an important marker for mortality, important marker for cardiovascular disease, for progression of kidney disease, but it's an important marker that you can intervene and try to see that if you keep on reducing it. And what's the importance of reduction? How much should you reduce to see whether that's going to make a difference or not? Can you tell me a figure that if you reduce proteinuria by this degree, this will be the advantage? Tell me a study. You are the most knowledgeable today.
Sir, by 50%?
Yeah, 50% reduction leads to what?
Sir, a decrease in cardiovascular
mortality. Significant cardiovascular mortality, total mortality, as well as progression of kidney disease. A 50% reduction in proteinuria leads to a significant reduction in end-stage kidney disease and progression of kidney disease. All the heat map, CKD heat map markers, they go down. So proteinuria is a significant. So you may not be able to get it down back to normal, but 50% reduction is a target that one should try to reduce. Okay, so proteinuria. So that's important.
Yes.
That's something again missed by nephrologists, and I'm sorry to say that. I usually go and give talks to physicians that they don't do albuminuria, but I'm surprised when I see people in practice. I have to search for where have people done albuminuria. It takes me 2 minutes, 5 minutes, sometimes even 10 minutes to search for albuminuria. They've done 20 visits to nephrologists, but I can't find a UACR or a UPCR. Okay, so that's something that needs to be done. Okay.
So now.
So other is urinary examination, proteinuria, estimation of proteinuria, or then what else? Kidney function you said you will do, and what else?
And
if you haven't vaccinated this person, you must vaccinate these persons. Hepatitis B. If
he was vaccinated.
No, she was vaccinated. But I'm saying that if you haven't, many times we may not be as good in this. You miss many patients. Even in your own clinic, you find that you haven't vaccinated some of these patients. So remind yourself again and again that you must vaccinate people to prevent diseases, and these are people who are going to be likely to require further immunosuppression also. So they might, so vaccinate them. And what are the adult vaccinations which for nephrologists are important? One, hepatitis B, pneumonia, influenza, Shingrix. Yeah, 59 years, important. So anyone above the age of 50 years at least, although in transplant patients and all, it could be done even in younger age group, but I think for patients who are 50s and above, so adult vaccination is something important which you should. These are safety practices which are important to incorporate in your day-to-day practice. You must bring it in your day-to-day, in your head. They should not be away from you. Every visit the patient, this must be something that you can make a chart and see whether you have ticked these. So make a checklist of things which nephrologists tend to forget. Okay, what else? Anything else that you would think you need to do to this patient? Obviously you will, this patient is on azathioprine, isn't it? She was on azathioprine. Suppose the patient is these days, is azathioprine better or for maintenance, or so what trial showed that?
Azathioprine is
Pardon?
both rituximab.
Which trial showed that azathioprine, there is something superior to azathioprine?
Ritazaram trial. Ritazaram trial.
Ritazaram trial. What was that trial?
Sir, Ritazaram trial compared rituximab with the azathioprine.
So how frequently was rituximab given?
It was given, sir, 6 monthly, 500 mg rituximab was given, and it was shown that the rituximab group is better than the azathioprine group.
Yes. So if people can afford, then they could be given 6 monthly rituximab, 500 milligrams per meter, 375 milligrams per meter square, or 500 milligram every 6 months. And so how long was the study? You know,
So
anyone?
2 years, I don't remember exactly the 2 years.
Yeah, about 2 years. So they usually gave it 3 doses. So 6 months, 1 year, 1.5 years, and then they closed the study. And then it was shown that during that period of time, the number of relapses that the patient had was much less. So there is a long-term arm of this study continuing still, and we will know the results. But azathioprine. But if there is somebody is on azathioprine, so you think is good, not good? What is there a concern in your mind if there is an azathioprine? What will you tell the patient? One? Yeah, one is that you will tell him that he will come with TLC and all that. So he will do TLC whenever you tell him to do it. After you known that he is stable at about, yes, uric acid lowering agents. Our patients from their neighbor would say that uric acid is gone 6.9 to 7.1, and they are worried that this uric acid is suddenly become 7.1 above the normal level, and therefore they need to take a drug. And their neighbor tells them that he is taking febuxostat, so he starts febuxostat. So what will happen?
So there will be neutropenia will be more severe.
Yeah, severe. Why?
Allopurinol.
Why?
Both has a common pathway inhibition, sir.
Which is what?
Azathioprine and the it has an action on the folic acid metabolism. Both inhibits that, so it causes more neutropenia when we combine these two.
Yeah. So when you combine it with febuxostat or Xyluric, both of them, allopurinol as well as febuxostat, both are xanthine oxidase inhibitors. So this will be, they will increase the availability, dose of. So the azathioprine cannot be metabolized when you have these drugs. So the dose of 50 milligram becomes something like an 150 milligram accumulation of this over a period of time, and they become severe neutropenia and all that. So severe toxicity, and sometimes fatal. People don't know. So you must educate your patients about them. Not only write it in your prescription, but tell them that nobody should use uric acid medicine whenever you're using azathioprine along with it. So that's important. Because many patients of ANCA vasculitis will still be in our country on azathioprine, because that's a good drug. Mycophenolate is not the good drug for this. Excuse me. So therefore, that's important. Good practices. These are important practices. So you'll have to tell your patients. I have seen patients who have taken this, and that's why it becomes important. There's a patient of mine, 25 years after transplant, after his retirement, went to Canada, a country where, so he goes there, although he was told, and he for 25 years was on azathioprine. He was from an era when there wasn't any cyclosporin, so he got transplanted that time. So he was 25 years later, but went to Canada after retirement to his children. Somebody there, he went to a regular kind of a physician who forgot probably and prescribed him febuxostat. So 2 months later, he is in the emergency with a hemoglobin of 4.8 and being investigated by hematologist and being told that he will need bone marrow transplant and all other things. And they forget, nobody looks at them. This can happen even in Canada. Nobody looks at that he is taking azathioprine along with, and this guy also forgot, because the trade name of febuxostat in that country was very different, so he didn't realize that this is a drug he's been told not to, and he was in an era when febuxostat was not available, so it was allopurinol he was more aware of. So somebody gave him febuxostat there, and he didn't realize that this is what So he decided, when somebody told him that he needs bone marrow, he thought it's better to come to India. So he came to me and I said that, who gave you this drug? I had told you not to take this drug. So we removed that drug and he didn't need bone marrow transplant. He recovered his. So it's important. Again.
Yes. So now coming to the current illness,
Yes.
she developed shortness of breath since 1st of March. To start with, it was of NYHA grade 1 class, to gradually increased up to NYHA class 3. It was associated with orthopnea, PND and bilateral pedal edema up to the level just above the ankle and distended neck veins. She gives history of hemopsis, which was around a half a cup to more than half a cup on few occasions. No relation to any posture or exertion is associated with this hemopsis. She was passing urine of around 1 liter per day and there was no history suggestive of hematuria or froth in the urine. There was no history of any fever, skin rash, oral ulcers, digital ulcers, joint pain, joint swelling. There is no history of any altered mental status, abnormal body movement, headache or burning or tingling sensation in the extremities. There was no history of any ear, nose or eye complaint or discharge from the same or epistaxis. No history of any complement or alternative medication intake or any change of medication from her usual medications, and neither she was on any blood thinners. So she was admitted to the nearby hospital for the above complaints and it was found out that her creatinine was 7 milligram per deciliter with urine output of around 1 liter. She was treated with IV antibiotics, oxygen support and other supportive therapy. CT scan was done over there and she was told that there is some blood in her lungs, and however with this with the management she was getting, the hemopsis persisted and the oxygen support increased, needing the NIB support. At this stage she was referred to our hospital. Then sir, past history. The past history, she is a known case of hypothyroidism in 1994, well controlled with 50 microgram of levothyroxine, hypertensive since 2000, well controlled with 2 drugs. There is no history that was suggestive of any eye involvement because of the same. Diabetes since 2012, there was no history of any eye involvement or history suggestive of neuropathy. The diabetes was well controlled and remembers the SB1C level remains between 5.5 to 6 with 2 drugs. One is dapagliflozin and premixed insulin. Known case of status post PPI insertion. There is no history of any tuberculosis or bronchial asthma is there.
When was PPI insertion done?
Sir, it was done in 2014, sir.
14. Okay. So she has a coronary artery disease also, or at that point of time,
sir,
I'm sure she would have had.
I asked about the same. She told that at that time when she had this complete heart block, they evaluated, but the coronary angiography was also done. But that time they showed there was no coronary artery disease was there.
No coronary artery disease. Okay.
And personal history, she belongs to a middle socio-economic group, widow, takes vegetable diet around 1000 kilocalorie per day. No history of any addiction, bowel bladder habit were normal sleep other than this recent acute illness period. Family history, a mother is a known case of CA breast and expired with complication related to it. Father had a history of CAD, died of myocardial infarction. They are 5 siblings, she is the 4th one, 2 brothers and 2 sisters. History of CAD in elder sister and younger brother. Obstetric and menstrual history, she had achieved menopause, what she remembers, around the age of 45 age, and 4 children. She had 4 children. She has 4 children, and all were born with normal vaginal delivery in hospital. Treatment history, she is on antihypertensive telmisartan for 40 milligram once daily, and Minipres XL 5 milligram at bedtime. For anti-diabetic medication, dapagliflozin 10 mg once daily. And on further asking, she gives no history of any UTI or any known complication related to it. and pre-mixed insulin twice daily. Thyroxine 50 microgram in the morning, oral iron, calcium tablets 500 mg twice daily, vitamin D, and azoran was going on 25 mg twice daily. Allergy history, there was no known allergy history was found in her case. So some case summary. So my
yeah, I think we've discussed a lot of this area. So come to the physical examination. Is there anything? And let's come to the last
examination,
the current illness.
The physical examination only
Positive findings.
pallor is positive, and the bilateral pedal end is still there, but decreased than before up to the level of ankle now. Neck vein, neck arteries were normal. Then sir, in all the peripheral pulse is regular 86 per minute. There was no radial or radiofemoral or any delay. All peripheral pulse were palpable. BP where there was no hypertension. All 4 limbs BP were normal, and there was no any ear, nose or eye deformity or ear discharge or any nose deformity. So only the respiratory system exam on auscultation, there is bilateral infrascapular area crepitations were there. The cardiovascular system, there is no finding is there, sir, and the rest of the systemic examination is
Was unremarkable.
normal.
So
Urine
what's,
routine
what's
was,
your clinical diagnosis in this?
sir, my
Current illness.
current illness, my clinical diagnosis is a hypothyroid, hypertensive, diabetic, status post PPI insertion, now presented with AKI. The cause of AKI being, sir, maybe pulmonary renal syndrome. Sir, pulmonary renal syndrome, first I would like to keep this systemic vasculitis, which is ANCA associated vasculitis, in view of there is a previous history and also the presentation. The second, I would like to rule out anti-GBM disease. Then the third, there might be a possibility that he presented with acute decompensated heart failure with cardiorenal syndrome and AKI. And fourth being any sepsis, AKI secondary to any LRT or pneumonia.
Okay. So anyone else with any other differential diagnosis? Anything else that you feel he hasn't covered? Okay. So what do you think is most likely?
Sir, I would, more chances, I think it's a systemic ANCA associated vasculitis leading to this complication. But again, as I said,
Was ANCA ever done in between?
sir, in between the ANCA was never followed up.
Never done or?
Never done.
Never done. So after the illness, none. So what's the importance of ANCA in the follow-up period? Huh? So sometimes you may have a patient, I give you 3 scenarios. You have a patient who had ANCA, C-ANCA positive vasculitis, treated, ANCA became negative, and then ANCA comes back, say after 2 years or so. There is another patient whose ANCA was positive, ANCA remains positive. Clinically patient is recovered, but ANCA is positive. ANCA is always positive. So it's not become negative ever.
The titers, increase in the titers.
No, they remain same. They remain same. So what do you do? Did somebody whose ANCA titers remain positive, although clinically patient is in remission?
Sir, if there is clinical remission and the urinary sediments are not showing any active sediment, or there is no other worsening of renal function, the ANCA titers has nothing to do. If there is,
so this happens in many of these diseases, that even in lupus sometimes anti-DS-DNA, which is a marker of lupus activity, the anti-DSness may never become negative in some of these patients, and therefore these patients may be immunologically or genetically different slightly as to why they don't become negative, but these patients don't necessarily behave poorly. They have gone into a clinical remission, and the ANCAs as well as anti-DS-DNA may not be a definite marker for this. Unless these rise or there is a clinical kind of a thing. But in someone who has an ANCA which has gone down and then ANCA starts coming up again, that may be a predictor of a clinical relapse in some patients. So, these are patients where you need to follow up these patients more clinically. So, even in those who have low levels of ANCA positivity or an increase in the activity at some point of time might produce a similar kind of a relapse in these patients. So, people with these kind of diseases, you must follow up these patients with ANCA in between, maybe every 6 months to a yearly, depending on the clinical course of these patients. So, ANCA is a marker of these diseases. So, you should monitor them, and it might give you a clinical clue, not necessarily to treat in isolation, but give you a clue that your patient may be more vulnerable to a relapse in next few months if you are doing it on a regular basis. So, that would be an important marker in such a case. This patient never had any ANCA done in ever. So, you can't say whether this patient this is related. So, you do not know ANCAs at this point of time. So, this could be a pulmonary renal syndrome, and the chances that this may be a relapse with ANCA, which is known. Relapses can be asymptomatic in many of these patients, and you may have a non-clinical kind of or subclinical kind of relapses in many of these patients, because you may have patient presenting and you do a biopsy and you find that the kidney is totally sclerosed, all glomerular sclerosis with interstitial inflammation or total atrophy, IFTA of more than 60%, 50%, 30%. So, kidney is gone. So, never a clinical relapse. They didn't have fever, they didn't have pulmonary hemorrhage, they didn't have any symptoms suggesting an acute kidney deterioration, but the kidney goes down. So, that's also possible in some of these diseases, that the relapses may be not clinical. You may not be able to detect it, and that can happen, but there can be a relapse like this, that patient's urine output is good this time.
Yes, sir.
But creatinine is 7 this time. Last time creatinine 7, urine output gone down.
Yes, mostly renal limited last time.
Huh?
Last time was mostly renal limited.
Yeah, that was an acute
Yes.
Crescentic Glomerulonephritis. This time it may be pulmonary hemorrhage. So, can you have a patient who presents initially with glomerular disease, and now this time if this is ANCA vasculitis, then this is now pulmonary hemorrhage. But clinically, although creatinine in this patient is high, but we do not know whether creatinine is high because of the acute Crescentic GN again. So, is it possible that there is no renal involvement, but there is now a pulmonary involvement?
There might be double positivity also, sir.
Yeah, there could be a double positivity, which is, he has put a possibility that this is anti-GBM. Now this has become. Are patients with ANCA vasculitis more prone to anti-GBM?
So, in 5% of the cases of ANCA, anti-GBM could be positive.
No, could be positive, but the question I am asking is ANCA vasculitis predisposing to?
Yes, sir.
Could it be? Yes, it could be. It could be, because you have here. So, anti-GBM is anti-GBM is
So it's a basement.
an antibody against basement membrane,
Basement membrane. The
collagen 4,
collagen 4 alpha.
alpha 3, alpha 5 chain,
Alpha.
isn't it? So, why is it there in the lung also? Why do we have lung hemorrhage in anti-GBM disease?
Because the glomerular basement membrane, the basement may also have the alpha 3 collagen.
Yeah,
over
the
there also.
pulmonary alveolar basement membrane also has a similar collagen 4
structure, sir.
with alpha 3, alpha 5, and that is why you may get a similar thing. And when you have hemorrhages, pulmonary hemorrhages because of vasculitis or other diseases which are, so the pulmonary involvement of non-specific etiology might be. There is generally either a viral illness, which is usually a pneumonia, the first episode of the epidemic, that flu epidemic that had happened in 2019 was followed by an anti-GBM disease. That is when it was first discovered also. So, anti-GBM disease at that point of time. So, you may have pulmonary disease or inhalation and some pulmonary toxicity that might. So, that might change the basement membrane, and therefore, you may have anti-GBM coming as a second illness. So, that's a fair argument also, and a fair differential diagnosis that you should include anti-GBM disease subsequent to if there is pulmonary hemorrhage now coming in into the picture, and that's a reasonable kind of thing. So that's possible, and then they may coexist in these patients, and that's also possible in these patients. Heart failure is a good differential diagnosis. And in heart failure, the pulmonary hemorrhage is because of
Sir, the pulmonary edema.
because of
that,
pulmonary,
the hemorrhage
pulmonary
is in
edema.
pulmonary.
So blood pressure. Okay. And sepsis obviously could be other reason, but she doesn't have other features of sepsis in the form of
Sir,
fever,
but
fever and
yes,
other.
sir, right now there is no fever, but again she was always immunocompromised and on azure, so fever is not a very specific
Maybe
marker of
immunosuppressive patients may
I would
not
like to
have
rule out, yeah.
typical symptoms of, and they may present just with low blood pressures and may present not necessarily with typical symptoms of. So fairly good argument. So do we have any further information you have? Something what happened? What do you find in this
The investigations.
do you have those?
Yes, sir. The urine routine is showing.
What's ANCA? That will be the most important first.
ANCA, ANCA.
Which ANCA was positive previously?
So the previously said they don't have the reports, but this time it's the P ANCA which is positive, sir.
Okay, this time P ANCA is positive?
MPO.
MPO.
Yes, sir.
Okay.
And the PR3 is negative.
And what's the level?
The MPO it's 89, sir.
89. Okay.
And the anti-GBM levels were normal, sir.
Okay.
And markers like other C3, C4 were also normal, 97 and 19 respectively.
Okay.
The urine showed protein of trace in amount, RBC high in number, WBC 29 per high power field, and there was no cast was there. And rest, sir, relevant investigations, the in CBC there was significant anemia, 6.3 was there with MCV of 92, and the platelets were 1,81,000. The RFT showed sodium 137, potassium. There was no electrolyte abnormality other than bicarbonate, which was 16. The urea was 189 in the beginning, and 8.1 is the creatinine at the presentation to our hospital. The electives was normal. There was no any transaminase was there, or no hypoproteinemia was there. Urine culture was sterile. There was no features. There was no coagulopathy in the coagulopathy test. We sent a CMV levels as well to rule out a chronic immunocompromised condition, and this the CMV levels were also normal, sir. And the CKD in the CKD status, the iron levels were 118. The transparent saturation is 73. The PTS was 88. Vitamin D is 34, and the phosphorus is 4.7. Thyroid levels were also normal. The lipid profiles were also normal. We didn't repeat a CT scan as it was done in the previous hospital. And urine culture is sterile. Sputum gram stain, no organism was found, but sputum fungal stain showed budding yeast with pseudo-hypy, and AAP was negative. And she was planned for biopsy after this current illness gets better.
What would be the purpose of finding out the kidney biopsy?
So, kidney biopsy in ANCA is mostly for diagnosis, but here diagnosis is done, then next to for the prognosis and how do we decide on the treatment. If because looking at her age, she is 79 years old, if there is, but as you have discussed, but it can be patchy also, but if we don't get a very active lesion, so to immunosuppress a old frail patient in our country, it will be a disaster, and infection might be
might kill her.
there.
So
And
you would
also-
want to understand the fertility and utility of further immunosuppression to save kidneys first, but she might need immunosuppression for lung.
Yes.
Because it looks like that this is ANCA vasculitis only,
Okay.
because MPO ANCA is positive, and there isn't any other clues also in your sputum or anything else that there is an active infection at this point of time. Kidney disease also probably would be related to ANCA, because although the urine output is okay, but kidney dysfunction is there, urine is still active, RBCs are there, proteinuria is not very significant, but but there is probably maybe sometimes you can get a tubulointerstitial disease also in these diseases, depending on the microvascular involvement because of ANCA. So, you might get not necessarily a glomerular disease, but this time could be a microvascular affecting predominantly tubular functions and all that. So, those are also well known in patients with vasculitis. So, you seem to have probably a patient who has a relapse, and this can happen. See, 12 years no relapse, in 12 years later you get a relapse. And she was on azathioprine, small dose 25 milligram twice daily. But as has been shown in our current trial, that despite these drugs you can get relapses in these patients, and relapses are frequent in vasculitis. And she's done well considering the severity of the disease at which she presented about 12-13 years back, but currently suffers from now. So, I would probably feel that this time, since there isn't anything else, maybe if they can afford, rituximab could be a reasonable good drug for her with either without steroids, and if you need to give some dose of cyclophosphamide depending on. So, lungs become pulmonary hemorrhage can be a severe, and if she gets another bout of pulmonary hemorrhage, she may die. So, I think rituximab in this kind of a setting would be extremely useful. In fact, my first patient way back 2004, 2005, talking about the first patient, and this was a patient who was in All India Institute of Medical Sciences, vasculitis. We didn't know he had vasculitis at that time because biopsy was not done, but became suddenly breathless. And since being a government hospital, sometimes you have too many patients and they don't get the kind of attention. This was a relatively rich patient who wanted better response from doctors. He ran away from there, came to us, and we found that he had vasculitis actually. So, and had pulmonary hemorrhage. His hemoglobin from All India Institute to Apollo Hospital dropped by about 6 grams. He had 3-4 bouts of pulmonary hemorrhage. So, rituximab had just come to India at that point of time. So, we used rituximab and he survived, and he died of myocardial infarction only 2 years back, and that's about good 27 years after, and became in remission, was dialysis free. He's never got, but he died of coronary heart disease. So, rituximab can be extremely useful in this kind of a setting. So, if she can afford it, probably that may be also less immunosuppressive, not as toxic. She's already received 1 dose of cyclophosphamide earlier also. Yes. So, cyclophosphamide second dose could be toxic, more toxic to her on a basis. So, I think rituximab probably may be a reasonably good drug if she can afford this. She is in Max, so she'll be able to afford. I guess she's reached there, then I'm sure she would take rituximab. So, rituximab can be useful in this kind of a setting. And I don't know about the kidney biopsy, but as she gets better in pulmonary hemorrhage, maybe a kidney biopsy at that point of time will tell you whether there is some tissue which is, but it would. I think rituximab probably would help her, maybe a kidney function as well, and we'll see. Any other questions you have? I think you have a time till 7:15 only, because we have to extricate this all. Yes?
So I have a query, sir. How long should the maintenance therapy be for ANCA associated vasculitis?
मेरे से न पूछो, इनसे पूछो, कोई वो बताओ भाई, how long do you want to give this therapy?
4 years, sir.
Huh?
Sir, 4 years, most of the studies.
No,
so
studies
48
did it for 4 years, but
4
what
years.
happens to them after 4 years? Do they discontinue it or whatever?
So they have said that you decrease as if we are giving azoran, then we decrease it by 25 mg every 3 months, and rituximab we stop rituximab and follow them up. That's
Yeah,
what-
so
as per
it
the
is,
KDIGO
you
guidelines.
don't know. Actually, this question has not been answered in the literature. So, you will not find a guideline on this. And so, you will have to follow up these patients. These are diseases which keep on recurring again and again. They go into a remission, they go into a good remission, but like this patient also good remission, but still has a relapse 12 years later. Many of them may have relapses more frequently actually. So, based on if you have had a relapse in a disease, you may have had a good response to start with, then you would discontinue therapy in about 3 to 5 years time, depending on how well the patient is remaining. So, I have been able to stop immunosuppression totally in many of these patients, and they may remain reasonably well. But there are occasional patients who will relapse very quickly and will continue to relapse, go into a remission again and relapse again. So, multiple relapses are possible in this, and people who have had more than 1 or 2 relapses, then I think you would continue some immunosuppression in these patients on a long term basis. And I think either azathioprine or maybe currently now even rituximab may be a reasonable kind of a choice to be given to them. And you could follow it with CD19 cell count basically to look at how long you should give it. It's depending on if they have had relapses, then I would need to keep some kind of immunosuppression in them. Like in lupus, many patients, if they have had a relapse, then there will be lifelong immunosuppression. So, even in ANCA vasculitis, sometimes you might have to. I have a patient who has been 30 years now with ANCA vasculitis, but has had 3 to 4 relapses over the last 30 years, and he is on immunosuppression right now and lifelong. It will continue lifelong. So, that is probably the answer to that question. But if you look at good evidence for this, yes, there is not going to be good evidence. So, if you look at the guidelines also, usually guidelines will tell you to follow it for about 3-4 years. That is most of the time the studies have followed these patients. Subsequently, your good judgment and clinical expertise is what they will look at. Anyone else? Anything else? Any other question you have, or anything that you would want to tell us that we haven't discussed? Anything that you feel?
So can MPO patients be done away with maintenance regimen?
ANCA is worse than MPO ANCA in certain sense that their overall outcomes may be somewhat more worse than the MPO ANCAs and all. MPOs ANCAs probably you might be able to, ANCAs you may have more relapses as well and more severe disease.
Many European studies on the basis of REO trial, because REO trial did not include maintenance regimen.
Yeah,
they have tried no maintenance for MPO groups.
Yeah, but it's very clinically very difficult to sort of. Pardon? No, we've tried removing immunosuppression after 4 or 5 years. If people have behaved well, then I have tried. Like this patient in 30 years, he was off immunosuppression to start with, but in about a year's time he had relapsed. This was ANCA, but we've done it in MPO ANCA as well, and they've also relapsed. ऐसा नहीं है कि नहीं है. So it's difficult to say whether MPO ANCA. Nobody will have that many kind of patients in their own expertise itself. So it's usually a registry data that will come out, which will suggest that what kind of patients might be. But it is true that ANCA patients probably are worse than the MPO ANCA patients. Any other question? I think next Thursday, all of you are invited to, those of you who are not being given a farewell, you can come and give your senior batches farewell. So we have a presentation and for the outgoing group, and then we have also a cocktail and a dinner, so you can enjoy some good time next Thursday. So all of you are invited next Thursday. This will be in, you will get an invitation as well. This will be in Lalit, Thursday in the evening at about same 6:30 or so. Okay. Okay. Lalit. Is there anything that you would want, something that, although we will ask that day also, but anything that you would want to be discussed? We usually discuss, we have some lectures also in between. You people decide not to present, or you fight with each other, I'm not going to present. So no one is coming forward to present, so then you usually have to pick up a lecture or so. So, but we discuss pathology, nuclear medicine, radiology, and then the clinical discussions anyway. And then we also have in other forums as well, we will start some different format of video online kind of classes for predominantly maybe a case-based discussion at a where how it should be sort of you can sort of learn as to how to sort of present and what could be the discussion points and other things. So that could be other ways of. So we might have other faculty members also coming and discussing those things. That's the other thing. But anything else that you would feel that you would need. So I feel that see DNB you need to be continuously studying, continuously asking questions. Don't study at the last moment and last minute. Then you don't do well. So we've had previously been extremely successful, but over the last 2-3 years we don't see as much success as some people fail. Actually, we have had initial 6 years, almost 95 to 99% pass percentages in these groups. So it's only tells me that ever since after COVID, things have started deteriorating, and that's because of these online classes as well as now that we've started physical. I do hope that all of you should demand it from your centers that they should teach, not only use you as workforce, but teach, but learn it. I think it depends on you ultimately. It's not going to be dependent on it's you. Your teachers will become as good as you are. So you have to become good to demand it from your teachers, and your teachers will rise. I can tell you, they will rise. So they don't rise because you not risen that much. So if you rise, then your teachers will rise. You challenge them. They will feel ashamed to come to the class, so they will read and they will come prepared. So it's important for you to demand what you need. So what you will demand, you will get. If you don't demand, nothing will come out. So if you don't feel that, so every day make it a point that what is it that you learned. In the evening, sit with yourself and see what is new that you have learned today, and see what is it that you need to ask, what question you have and which needs to be answered. So look for those answers and all that. So when more you read those, try to look for these specific answers, discuss between yourself. That's the best way of. So every day, don't go home 5 o'clock. I know these days many of you are married, you have a wife waiting for you or a husband waiting for you, a child sometimes waiting for you. So then it becomes that you leave at 5. But try to see if you can spend 2 hours beyond your regular work with each other and pick up topics which you discuss. That's what will keep your memories good. The moment you fight, no, this is not right, and then you go and find out the books, and next day find out who was right. So that's the best way to study actually. You can pick up 3 topics, you don't have to read everything, but 3 topics being discussed, and 2 of them you can discuss that, and that would be probably the best way of learning from each other. And then you can obviously go higher. Okay, all the best.